Hello and welcome. My name is Emily Messing, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation is Care for the Caregiver. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during this presentation. This is the key abbreviation that will be used in this presentation. Starting us off, I would like to go over a self-assessment question. Which of the following stages is not part of the second victim recovery process? A. Chaos and accident response. B. Intrusive reflections. C. Destroying personal integrity. D. Enduring the Inquisition. E. Obtaining emotional support. F. Moving on, surviving. When we return to the assessment question at the end of the presentation, I will provide the answer and discuss the rationale. Before we jump into the bulk of this presentation, which is focused on caring for the caregivers or the second victims, I want to first define what the first victims are. So as medication safety specialists, many of us are familiar with the events that take place once an event has been identified. So the first thing that we do is provide immediate response and care to the patient who has experienced the adverse event. That patient and the patient's family members are referred to as the first victims, as they're the ones that are experiencing the immediate impact of the event that has occurred. Once we've cared for those patients and made sure that their immediate needs are met, the attention then turns to the post-event investigation to help identify what happened and the factors that contributed to that event. Oftentimes, these investigations reveal that the healthcare workers involved in these adverse events are experienced, well-intentioned staff that are instead surrounded by very complex systems and possibly poorly designed workflows. Despite all of this, historically, very few resources have been dedicated to helping these healthcare workers cope with their emotions post-events. Oftentimes, the staffing needs of the unit or of the institution require that that individual immediately return to work and doesn't allow them time to process their emotions of what has just happened. As a result, many of these individuals will have to deal with these emotions alone, and without proper support and resources, they ultimately will suffer. While probably all of us have heard the expression, to err is human, Albert Wu points out that within modern medicine, there strangely is no place for mistakes when it comes to providers. Society has entrusted physicians with the burden of understanding and dealing with illness. Although it is often said that doctors are only human, technological wonders, the apparent precision of laboratory tests, and the innovations that present tangible images of illnesses have in fact created an expectation of perfection. And when we think about this, we can only imagine the large burden that this would have on healthcare providers when a mistake does happen. Which brings us to the term second victim. The term second victim was initially coined by Albert Wu in 2000 and is defined as a healthcare provider who is involved in an unanticipated adverse patient event, in a medical error, and/or a patient-related injury. These healthcare providers become victimized and they feel traumatized by the event. Frequently, these individuals feel personally responsible for the patient outcome, and many of them feel as though they have failed the patient. Oftentimes, this results in them second-guessing their clinical skills and their knowledge base as they continuously replay the event in their minds. As we learn about second victims, it's important to recognize that any healthcare provider could be susceptible to experiencing second victim phenomenon. Oftentimes, the literature points to either physicians or nurses, but more recently, there's expanding literature out there talking about other healthcare providers, such as pharmacists and pharmacy technicians, experiencing second victim phenomenon and needing just as many resources as their physician counterparts. It's important for us to recognize the potential impact that second victim phenomenon can have on our healthcare workers that are involved in an event. Many second victims report that the error had a negative impact on their professional and personal lives. On a professional level, many healthcare workers reported feeling deeply wounded. They oftentimes may lose their nerve in the professional setting. They report feeling burnt out, and some may even seek solace in alcohol or drugs. Looking at a personal level, we've also seen an increased rate of suicides in our healthcare workers. In many instances, it's because of the pressure associated with the profession and the feelings of despair after making a mistake that could ultimately lead to a patient's demise that takes such a toll on our healthcare workers. Looking at pharmacists in 2014, the age-adjusted suicide rate was 18.2 per 100,000 pharmacists, which is significantly higher than when we think about that suicide rate in the general population. To help make the second victim phenomenon more real, I've provided a quote here from Eric Kropp, who's a pharmacist who was involved in a fatal medication error for a pediatric patient. Eric said, "During the first few weeks following the incident, I felt isolated from my colleagues in the hospital. No one checked on me or offered support. I feared going to work. I experienced depression, guilt, humiliation, remorse, and frustration. The day I was dismissed from my employment at the hospital, I truthfully wanted to die. On the way home that day, I thought of turning the wheel into a bridge pylon and ending it all. I received a call from my mother at that very moment. It was the only thing that stopped me." So let that sink in for a moment as we continue to go through this presentation, and I hope his words really are a sort of a call to action for you of why it's so important that our organizations provide support to these second victims. Another reason that it's so important to have established programs to support second victims is that actually so many healthcare workers have reported feeling like a second victim themselves. While it's really difficult to measure the actual prevalence of second victim phenomenon, studies do estimate that can be as high as around 43% of healthcare workers working within organizations. If you're curious about what this percentage or rate of second victim phenomenon is within either your organization or your division, I would definitely encourage you to check out the article that was published by the University of Texas MD Anderson Cancer Center's Division of Pharmacy Patient Safety Subcommittee Work Group. What this group did is they sought to see how prevalent second victim phenomenon was within their department in order to determine what the best supportive programs could be for them. So at MD Anderson, they found that close to 40% of questionnaire respondents did perceive experiencing second victim syndrome, and that a peer support program was the most desired type of program and support by their respondents. So this allowed them to really customize the level of resources and support that they were providing to their staff based off of what they felt the most perceived need was. Next, we're going to focus on what the second victim trajectory looks like. Just like we go through the stages of grief after losing someone that is near and dear to us, second victims also go through predictable stages before they're able to move on or heal. The first phase is characterized as chaos and accident response. During this phase, the second victim and the whole healthcare team are really going to be focused on making sure that the immediate needs of the patient are met. They might be communicating with the family if needed, but ultimately the goal here is really to stabilize and treat the patient. Immediately following that, the second victim might feel distracted, they might be immersed in self-reflection. Oftentimes they're sort of caught feeling like, what just happened? So here we have a quote by a second victim who is unidentified. They say, "Right after I realized I made a mistake, I was having trouble concentrating. It was reassuring that I had people to help out. I was in such disbelief that this had happened." So this is really important when we think about taking care of our caregivers and whether they are immediately thrown back into patient responsibilities. It might not be the best thing for them, and it also might not be the best thing for the patient. The second stage is intrusive reflection. During this stage, the second victim often will reenact and play the event over and over again in their mind. They might be asking themselves a series of what-if questions. They might be saying, if only I had done this, or if only I had done that. And oftentimes this results in a lot of feelings of inadequacy and might result in that person self-isolating. Here we see a second victim say, "I started to doubt myself. There were some things that I thought maybe if I had done it this way, it wouldn't have happened. but everything was more clear looking at things in retrospect. I lost my confidence for some time. After experiencing the intrusive reflection, second victims often move on to a phase known as restoring personal integrity. During this phase, the second victim oftentimes will doubt their future career professional choice. They will be surrounded with thoughts of what are other people thinking of me, feeling like everyone knew what happened and be thinking less of them because of it. Oftentimes they'll be left thinking, will I ever be trusted again by my colleagues? And this results in increased levels of self-doubt, which can play out as lack of clinical confidence, which ultimately will impact their ability to carry out their jobs. Here we see a quote from a second victim saying, I thought every single day for months I'd walk in and think, everyone knows what happened. And I thought these people are never going to trust me again. The fourth stage is known as enduring the inquisition. During this stage, the second victim begins to wonder about the repercussions of the event and how it's going to impact them professionally and personally. Oftentimes, they're wondering if they're going to lose their job or lose their license, or will they be involved in a lawsuit. What's really important during this phase is that a lot of times second victims might feel really isolated and not know who to talk to about this. So as a reminder, as we're going through thinking about these different stages, imagine kind of going through this or something similar yourself and not knowing who you're allowed to talk to or having someone to talk to. Here we have a second victim say, I didn't know what to do or who to talk to professionally or legally. Clearly, I know we needed to keep that quiet. It might have been helpful to be able to talk to someone else, but I couldn't do that. So imagine having all of these intrusive thoughts and not being able to talk to anyone about it there. This really shows why it's so important that hospitals have established programs to help support these second victims and help them navigate these complex thoughts that they might be experiencing as they move through the second victim trajectory. As we mentioned on the last slide, as the second victims are moving through the different stages of the second victim trajectory, there are a lot of complex feelings that the second victims are experiencing. However, in stage 5, which is known as obtaining emotional first aid, oftentimes the second victims start to really feel like it would be important to be able to talk to someone. Here, they've already kind of endured the inquisition, they've already been reflecting on all of the what if thoughts leading up to the event, but now they feel like it's all sort of starting to bottle up and they really want to be able to talk to someone. But oftentimes, without a second victim program established, it's really unclear where these individuals can go. They feel like they can't talk to their colleagues about it because they don't want them to think less of them. But then oftentimes thinking about healthcare with all of the HIPAA considerations, there's sometimes confusion around who people can talk to outside of the hospital or outside of the institution. Here we see one second victim say, there was nobody I could tell, not even my husband. All I could say was, I've had a really horrible day. Imagine having a really, really horrible day, maybe one of the worst days in your professional career, and not being able to confide with the people of your life. That's what's happening with these second victims when they don't know who they're able to talk to. And finally, we have stage 6, which is known as moving on. Like the entire second victim trajectory, stage 6 is a very individualized experience. We've talked about the previous stages and how they can reflect similar stages and similar emotions and feelings that individuals can experience when they're experiencing grief. Stage 6 can present in 3 different ways, as individuals thriving, surviving, or dropping out. And let's take a look at what each of those look like. Let's first start with dropping out. As you can imagine, experiencing an event that's so traumatic, like ones that our second victims do go through, sometimes the emotions and the feelings that are resulting from this event can just be too much for the individual, and they might result in wanting them to experience something new. Sometimes that can look like dropping out of the profession completely, but other times it can look like just changing your position within the profession. Here we have one second victim who says, I actually ended up moving to a different floor. My new supervisor who has oriented me expressed confidence and belief in me and helped me regrow my own sense of confidence and self-belief. Sometimes what these second victims desire is a fresh start. They want to work with individuals who they feel like might not know anything of the event. It allows them to have this fresh opportunity to rebuild their confidence and rebuild their identity in their professional career. Next, we have surviving. Surviving, unlike dropping out, are individuals that have found different ways of coping with the event, and develop different coping mechanisms for themselves to continue on with the profession or continue on in the position that they're working with. While they might not have found a way to forgive themselves, and they ultimately will likely not forget the details of this event, they found a way to begin to move on and continue on with their career. And lastly, we have thriving. In the thriving phase of the second victim trajectory, it really reflects an individual who has not only recovered, but who has been able to learn from this event. They've developed stronger coping mechanisms from the individuals we referenced in the surviving slide, and they've really turned their experience into action. This might be them serving as an advocate for patient safety or peer support. They'll likely get involved in initiatives within their unit or their hospital to help others learn from the type of event that they went through. Ultimately, thriving is what we should really aim for as we work on developing second victim programs and help support our healthcare workers through these types of events. Now that we've finished reviewing the very individualized second victim trajectory, I want to now turn our attention to the second victim resources. I hope that you've seen throughout this presentation why it's so important for programs to have established resources for second victims. But ultimately, the most important reason is that by having these support systems in place, we can really impact the trajectory of the second victim experience. So support for second victims has been shown to be able to positively impact the recovery process and help more second victims reach that thriving stage that we just went over. One of the ways that we can do this is by identifying the need for second victim support early on in an event investigation. What that support looks like can be highly individualized and can be developed and determined by institutions. A support program is likely to be most effective if it's part of a comprehensive process to responding to patient safety incidents. It should include plans for taking action, but to correct the system, but also it should have a plan to support the second victims on an organizational level. If your institution is looking to roll out or implement a second victim support program, I would definitely recommend using the 4U team out of the University of Missouri as an excellent resource to help base your program off of. So what we're looking at on the screen here is a visual of what the 4U team developed as part of their process to develop a complete second victim program for their healthcare workers and providers that were involved in traumatic events. Ultimately, what they landed on was a 3-tier approach, which we're looking at here. So tier 1 is composed of local support. These are managers, supervisors, or peers on the unit level that can provide one-on-one reassurance and support to the second victims. Oftentimes, these are the individuals that are deployed first because they're the ones that are most easily accessible. They might be aware of the event more quickly. These individuals have undergone specialized training so that they are able to, one, identify second victims that might be needing help, and then also feel comfortable and confident in these interactions with the second victims. Sometimes, though, the local level support might feel like it's not enough for individuals. So what the University of Missouri has developed is the second tier, which is composed of more specialized, trained peer supporters and support individuals. These individuals might be patient safety officers or medication specialists, like yourselves, who have additional training and are available to be consulted and contacted when healthcare workers might need more one-on-one crisis intervention. They can serve as mentors and help guide the second victim through their trajectory process, and also provide them to support throughout the event investigation and potential litigation that might come from this event. Recognizing, though, even with peer supporters, there might be individuals that require a higher level of care. So University of Missouri has developed the 3rd tier, which is composed of an expedited referral network that's made up of individuals who may work for the Employee Assistance Program, social workers, or psychologists or therapists who have just more training in this area when either the trained peer supporters or the local unit support might not be enough to really help these individuals. Peer supporters are a critical component of a successful second victim program. Peer supporters are crucial in the second victim program because they provide emotional validation, they can share a mutual understanding of what the healthcare worker is going through, and oftentimes they're available to provide immediate support to the healthcare worker. These peer supporters are able to relate to the experience that the healthcare worker may be going through either in the events that led up to the event or the event themselves. They can oftentimes help reduce the feelings of isolation that the second victim might be feeling and help them normalize the reactions that they're going through. Ultimately, peer supporters are able to promote psychological recovery in a trusted and non-judgmental environment. So as we're working with our peer supporters, we want to make sure that they have the appropriate training and they feel confident and comfortable having these interactions with second victims. Oftentimes, we recommend that when they first meet with the healthcare worker, they introduce themselves as a peer supporter and explain the goal of the peer support. From there, they can talk through the experience that the healthcare worker is going through and sometimes just be there to listen to the story and be a helping hand. So some of the questions we might encourage our peer supporters to ask the second victim, are how do you feel about what happened? What parts are you having problems with right now? Are you having any unusual or disruptive thoughts? And based off the responses that the healthcare worker is able to give to the peer supporter can determine if they feel like they're able to continue working with this healthcare worker or if it's important for them to escalate up to a higher level of care and support. In addition to providing emotional first aid to the second victim, it's important that the peer supporter also discuss normal reactions and behaviors that the second victim might experience as they move through the different stages of the second victim trajectory. On a physical side, the second victim might experience some sleep disturbances, which can result in extreme fatigue or difficulty concentrating. They might also feel like they're having rapid heart rates at times when they're thinking back to the event or experience increased blood pressure. These are all very normal, and the peer supporter should let the second victim know that it's okay to be feeling this way and to express those feelings as they work through the process of moving on from the event. It's also important that the peer supporter let the second victim know what types of destructive behaviors they should look out for in order to know when they should seek additional help. Some of the ways that the peer supporter can express to the second victim that they are not alone through this process and let them know that the recovery process, again, a lot like grief, is going to take some time. Some of the ways that they can convey this or express this to the second victim is by saying things like, "This might take some time," or "I'm so sorry that you're going through this." This will help make the second victim feel less alone and know that they can lean on the peer supporter as they move through the recovery process. As a peer supporter yourself or someone who might advocate for the training and the development of a peer support program, it's important to recognize that this is going to be a process. So oftentimes when peer supporters are working with second victims, there are oftentimes that there needs to be more than one conversation. Additional visits may be needed, and these might be needed in person rather than over the phone or over Zoom. But regardless of whether the second victim reaches out to you again as a peer supporter, it's really important that you as the peer supporter check in within a few days or a few weeks to make sure that the second victim or the caregiver is doing okay. Throughout all of these conversations, as we mentioned earlier, there are times where caregivers may need referral to a higher level of care than you as the peer supporter are able to provide. And so it's really important that you have these touch bases with the healthcare worker in order to determine if that referral to higher level of care is needed. I recognize that we've gone through a lot of material in a very short period of time today, so I wanted to provide additional resources to you if this is an area that you're interested in exploring further, and if maybe this is something that your institution is looking to implement. So on the slides and included in the reference section at the end, we have additional programs that have been successfully rolled out to help support second victims in the healthcare setting. We talked about the 4U team earlier when we were talking about Scott's 3-tier approach, and we're going to next look a little bit deeper into the You Matter program. The 4U Matter program at Nationwide Children's Hospital was created in response to the recognition that healthcare providers within the institution involved in adverse events were experiencing significant emotional distress. The program was developed to offer peer support and psychological assistance to help staff cope with these traumatic events. And the way that they were going to do that was by fostering a supportive culture focused on emotional recovery and resilience. Like the 4U team, the You Matter program uses Scott's three-tier model to support second victims. So at Nationwide Children's, all staff were trained as part of the Tier 1 response. During this training, it was really focused on how they can identify a second victim. From there, they trained additional staff to be peer supporters, and their Tier 3, like the 4U program, involved chaplains, social workers, and clinical psychologists. Since the program started in 2013, there had been 232 documented peer encounters as of a publication in 2017. So you can imagine even since that time, how many more healthcare workers were actually helped by this program. Now back to our self-assessment question. Which of the following stages is not part of the second victim recovery process? A, chaos and accident response. B, intrusive reflections. C, destroying personal integrity. D, enduring the Inquisition. E, obtaining emotional support. F, moving on, surviving. And for those of you that chose C, destroying personal integrity, that is correct, as that is not part of the second victim recovery process. What we're actually looking for here is restoring personal integrity. In conclusion, healthcare workers involved in incidents of patient harm are at risk for emotional harm. Taking care of healthcare workers after a serious, unanticipated outcome is an important step in keeping these workers both emotionally healthy and engaged in their work delivering safe care to our patients. As a leader, understanding this need and providing support should be a key component of any patient safety program. These are the references used to develop this presentation. Thank you for your time and participation.